My name is Dr. Dickson Mwakangalu. I'm a medical doctor and public health specialist, and I work at Brac NGO, where we work in Africa and Asia. We have operations in Africa in about 7 countries now, and we are looking to possibly having operations in Kenya by end of this year or early next year, when we introduce our microfinance infrastructure and then have the NGO registered. Then we can start implementing social empowerment programs at community level. So based to your question, yes, I think for me, there is no health service delivery if there are no commodities. So health commodities, especially medicines, are very critical. And we have seen many times even, our old people, when they go to a health facility and they don't get even paracetamol, they come complaining bitterly that I went to that hospital and I didn't get even paracetamol. And many people come to the hospitals because of pain anyway. So I think the county governments need to take the responsibility of delivering health services critical, because health services is devolved according to the Kenyan Constitution. And so they need to have adequate budgets for procurement of these commodities. They need to do proper forecasting and quantification of the required drugs so that they have enough to sustain them. And also, as they do that, for the lowest level facilities where they have community health promoters, they need to also plan and budget for the drugs that can use to refill the kits that the community health promoters use as they visit households and do their work at household level. So I think for me to address this, we can learn from other countries. I think Addis Ababa and Ethiopia and Rwanda have done very well in the community health programming. It is important, first of all, to have laws and policies that recognize this important cadre as healthcare workers. Once that is done, then they can be handled like the nurses, the clinical officers and the doctors, where they're put in an official government payroll, so that they know they have a contract, they have work to do, and they will get something at the end of the day. I think Rwanda has done very well. They have that cadre and the government pays them. Now for us, the government, because they have this UHC agenda and they have the health promoters as part of the critical staff, have agreed with the county government that they will be paying 2,500 at national level, and then the county government pays 2,500. For me, I find it not a very impressive model. I see a disconnect, because you may realize that sometimes the county government has paid their 2,500 and the national government has delayed in sending the money. And that is why you are saying maybe some of them have stayed for 5 months without getting the money. For me, the best way would probably be to put this money together. If the national government, since health services is devolved, in my opinion, they can put those resources and push them to the county government, so that then the county governments can have this money and they can pay the 5,000 to the community health workers. But remember, when I was talking in the panel, I mentioned some of the innovative models that Brac has done in other countries, in Bangladesh and in Africa, Uganda, Sierra Leone and Liberia, where we have used an entrepreneurship model for community health workers. So we give them non-medical items where they can also sell as if they visit the households. Remember, I mentioned things like energy-saving GCOs. Right now, we are grappling with issues of climate change, and we need to have climate adaptation, approaches. And if you go to those villages, they cook with firewood. So how do you reduce them using more firewood? So energy-saving GCOs. So the community health workers can bring those in addressing issues of sanitation. They have the SATO toilets, which they can sell. They have the Uji that is fortified for nutrition status of the children and pregnant mothers. They can sell. So they can be empowered with such social enterprise ideas, and they're able to generate something additional that can keep them motivated. And then in Brac, what we have done is also to have these community health workers in groups, and then we link them to our microfinance. We train them on education literacy, financial literacy. They can be able to access loans and other financial products, so that they can be able to invest and do their things on day to day. That is sustainable. It will keep them motivated, and they will do their work.